Hello, I'm Nancy Rowe from Rush University Medical Center and the current chair for the Hepatology Interest Group for WGO. I'm proud to introduce the following symposia in recognition of World Hepatitis Day. This hepatitis C symposia, called Global Burden of Viral Hepatitis, takes a closer look at hepatitis C. We are honored to involve multiple speakers, including Professor Mohamed El-Kassas from Egypt, Professor Gaspar from Portugal, and Professor Mustapha Benazzouz from Morocco. Please enjoy.
Hi, everybody. This is Mohamed El-Kassas, Professor of Endemic Medicine and Hepatogastroenterology, Helwan University, Egypt, President of the Egyptian Association for Research and Training in Hepatogastroenterology, ERS. Our talk today will be about the hepatitis C virus screening guideline changes. As you all know, chronic hepatitis C is a progressive disease passing from healthy liver to fibrotic liver to cirrhotic liver with few or no symptoms, and this could occur over decades. Recently, the introduced the directly acting antiviral therapy or all oral therapy raised the response rates to antiviral therapy to more than 95% with fewer side effects and high tolerability. The WHO goal was to eliminate viral hepatitis B and C by the year 2030. This means that we have to reduce new infections, we have to reduce the overall infection of viral hepatitis by 90%. The problem that face this elimination is that only 21% of the estimated number of people living with hepatitis C in 2019, only this number was diagnosed, and of course this varies by region. To achieve this goal of elimination, we had recent changes in the screening recommendations for hepatitis C in different guidelines. To start with, the guideline of the WHO, the previous WHO guidelines in 2017 adopted two approaches. The first is the focused testing for the most affected population and high-risk populations, including people who inject drugs, people in prisons, men who have sex with men, sex workers, HIV infected, persons with tattoos, transfusion, and some immigrants, and those with a clinical suspicion of chronic viral hepatitis, family members and children of patients and healthcare workers. The second approach is the general population testing in settings with relatively high prevalence of HCV antibody exceeding 2%. This was the 2017 recommendations, but the new recommendation in 2021 introduced a new screening method, which is the hepatitis C virus self-testing, which should be, according to the guidelines, offered as an additional approach to hepatitis C virus testing services with strong recommendations and moderate certainty evidence. Hepatitis C virus self-testing, according to the WHO guidelines, needs to be followed by linkage to appropriate post-test services, including confirmation of the viremic infections treatment, care, and referral services according to national standards. This is the scheme for self-testing strategy. After performing the self-testing, we have to confirm the result with another testing and then link the patient to care. The next recommendations for screening or guidance is the CDC 2020 recommendations for screening. This recommendation guidelines was issued on April 10th, 2020, and this new recommendation have two major changes compared with the previous recommendations. The first is that all adults in the United States who aged 18 years and older should have hepatitis C virus screening at least once in their lifetime. And the second is that hepatitis C virus screening should be performed for all pregnant persons during each pregnancy. Additionally, the CDC continues to recommend screening persons for hepatitis C regardless of the age if risk factors for acquiring hepatitis C are present, with repeat periodic screening in persons who have ongoing sex for acquiring hepatitis C. This new CDC recommendation expands prior guidance that recommended routine hepatitis C virus screening for all persons born between 1945 and 1965. This is a recommendation for CDC 2020 with the high-risk population targeted. Historically, and the previous recommendation in 1998, the CDC issued the recommendation only for risk-based hepatitis C virus testing as a part of an overall strategy to prevent and control hepatitis C virus. This is a recommendation for 1998 by CDC, and these are the risk groups that were only targeted by screening. Actually, they discovered that there is large limitations of using the only risk-based screening. The main limitation is that the effectiveness of that type of screening, only 60% of persons living with hepatitis C had their initial testing ordered at a physician office, and only 45% underwent testing because of clinical indication related to liver disease, and less than 25% of persons had identifiable risk factors for acquiring hepatitis C. Because of that, the CDC adjusted their recommendation to the current one. The next recommendation is the United States Preventive Service Task Force recommendation, or Usp Stf Recommendation, which was issued in March 2020. This recommendation says that we recommend to have routine screening for all adults in the United States aged from 18 to 79 years old, including pregnant women. The recommendation notes that most adults will require hepatitis C virus screening only once, but those with ongoing risk of acquiring hepatitis C will need periodic screening. For persons less than 18 years or above 79 years old, screening for hepatitis C can be considered if individual is considered at a high risk of acquiring hepatitis C. This is the recommendation for the Usp Stf 2020. The next recommendation is the combined recommendation between the American Association for Study of Liver Disease and the Infectious Disease Society of America for hepatitis C treatment and management guidance. The recommendation, AASLD and ETSA, was first, we have one-time routine opt-out hepatitis C virus testing for all individuals aged 18 years and older. Secondly, one-time testing for persons younger than 18 years who have increased the risk of acquiring hepatitis C. Third, periodic testing for persons who have risk activity for acquiring hepatitis C. And finally, annual testing for men with HIV who have condomless sex with men, men who have sex with men and are on HIV pre-exposure prophylaxis, and people who inject drugs. These recommendations for testing incorporate per-cohort screening as well as testing based on risk behavior, risk exposure, and medical conditions associated with acquisition of hepatitis C. The last recommendation is EASL recommendation, which was updated in 2020, and it adopted screening strategies, screening according to local epidemiology and within framework of national plans. Screening may include at-risk populations, PERS cohort testing, and general population testing in areas with intermediate to high prevalence from 2 to 5% of the population with HCV antibody positive, and screening based on detection of serum or plasma anti-hepatitis C virus antibody using ELISA technique. These changes in guidelines recently have some rationale. The first is that there was a detected change in hepatitis C virus epidemiology in different regions of the world, with a major surge, for example, in new cases of hepatitis C in the United States. The recently introduced directly acting antivirals with its very high efficacy, and also the cost of DAAs is going to be driven down by the recent competitive market forces, which allowed us to treat larger number of patients compared with 2015, for example, upon the introduction of DAAs, where the cost was a very big obstacles facing treatment of large number of people with this therapy. Also, the directly acting antivirals proved to have a positive impact on the natural history of hepatitis C, with a major reduction in hepatocellular carcinoma risk and liver-related mortality. Our last topic will be the Egyptian experience in screening and the large campaign for screening of all Egyptian population, which was called 100 Million Wealth. This large campaign started in October 2018, targeting the screening of 65 million population during a period of 7 months. This large campaign depended on the available database for Egyptian presidential elections to target all population aged above 18 years. All Egyptian governorates were distributed over 3 stages. Every stage lasts for 2 to 3 months, and over a period of 7 months, there was a large media campaign in television, radio, newspaper, social media campaign. This is a brochures of the campaign. The campaign included more than 5,000 screening units, including primary healthcare centers, hospitals, mobile units, and with more than 20,000 working teams working for 12 hours a day. The campaign depends on the rapid testing for hepatitis C, and those who were detected positive to hepatitis C virus antibody were referred to the care to complete their investigations and start treatment for free on the government expenses. This campaign succeeded in screening 57 million citizens over the 7 months period. 2.2 million had hepatitis C virus antibody positive, 1.5 million were hepatitis C virus PCR positive or viremic, and actually 1 million patients started treatment already. The results of this screening campaign was published in many scientific publications coming from Egypt. Thank you, and of course I invite you to attend the World Congress of Gastroenterology 2022 in 12 to 14 December in Dubai. Thanks.
Hello, my name is Rui Gaspar. I'm a gastroenterologist and hepatologist in Porto, in Centro Hospitalar São João in Portugal. And I'm talking in the webinar series of the global burden of viral hepatitis. So my theme is hepatitis C, simplified therapy. So as you know, hepatitis C is a world health-wide problem with a lot of countries with a lot of people infected with hepatitis C. You can see that you can have a high prevalence of hepatitis C in a lot of countries in Africa, also in Asia, but it is still a problem in many countries in Europe and also United States and South America. So it affects almost every country in the world. This is an interesting slide about the numbers of hepatitis C. It was first described in 1989, so a long way till now. It is also the most common blood-borne infection in the US, and 3% of people worldwide live hepatitis C. A very, very great problem is that almost half of the people that have hepatitis C, they still don't know it. So it's very important to screen and to detect as soon as possible. Here is also an important slide about the evolution of treatment in hepatitis C. So as you can see, it was first described in 1989. The first treatment appeared 2 years after the interferon during 48 weeks and only available for genotype 1, 2, and 3. 10 years later, it started to appear the PEG interferon, that the great novelty of this treatment it is that was available for all genotypes. Almost 11 years after, it started to appear the direct antiviral agent plus the PEG interferon regimen. But as you can see, the cure rate before the direct antiviral agent was only 40 to 85%, and it was more close to 40 than to 85%. After that, in 2015, more or less, it started the new revolution of treatment for hepatitis C. So it appeared that all oral direct antiviral agents that could be used for between 12 and 45 weeks, and they presented a cure rate of more than 90%. So now we are talking about the pan-genotypic DAAs, that is the great novelty in the last few years, that we can use between 80 and 16 weeks, and it has also a very, very high rate of cure, more than 90%, more than 95%, almost 100% of cure rates. So in the beginning, it was really difficult to talk about treatment about hepatitis C. We have different classes of medications, also with very difficult names. So it was really hard to know about all the things about the hepatitis C treatment. So it was the opposite of the title of my communication. It was everything, but not simplified. When we use the new DAAs versus the interferon therapy, what you can see is that the new treatment that has a sustained virological response of more than 90%. It has fewer side effects. Some patients talk about headaches, but it's very light and they still only for 1-2 days. So they can cure a large proportion of all HCV patients. On the other hand, if you look to the interferon treatment, we see that we have only sustained virological response of 40 to 75%. We have a lot of contraindications, but the most important thing, they have a lot of side effects. Most of the patients cannot be cured because they cannot continue the treatment because of fatigue, one of the most side effects, most common side effects of interferon. So it has a low impact of cure because almost half of the patients cannot finish treatment. With the new treatments, we can see that the long-term medical cost avoided is very large because they have a great reduction in hepatitis C related hepatocellular carcinoma, almost 45% of cases avoided, but also of more cirrhosis cases avoided, less than 61%, and also more liver transplant cases avoided, less than 50%. So we have a great reduction in all the consequences of long-term of HCV infection. We have also high success rates of treatment, so retreatment is very rare, so we can avoid also that costs. And there are some studies that show that after treatment, the productivity gained by the patients are really massive. So it's very important, and we are also preventing transmission and reducing the number of new people infected with hepatitis B. Also, a very important thing in the last few years that is that all patients should be treated. In the beginning, we only treated patients with high degrees of fibrosis, F3 or F4, but now we treat all the people. As soon as we know that we have an infection, we start treatment of HIV. So if we have medications that have almost no side effects, if they are really effective, if everyone is available to treat, we want to use it and to eliminate viral hepatitis. So the main aim of WGO and WHO is to eliminate viral hepatitis in 2030. What do we mean about eliminate viral hepatitis? So we want to have a 90% reduction in the new case of chronic hepatitis B and C by 2030. So if we avoid transmissions, if we treat as soon as possible, we won't have the case of chronic hepatitis B and C. We also want to have a 65% reduction in hepatitis B and C new cases, and also want to treat 80% of eligible persons with chronic hepatitis B and C by the year 2030. How can we achieve elimination? Very important. Early diagnosis. So there are a lot of countries and societies that suggest once a lifetime screening. And for that is also very important that we have diagnosis tests with reduced costs. But another very important thing is to focus on the difficult populations to treat. So microelimination. If in the beginning we treat all the patients that come to meet us and want to be treated, they come to the hospital because they know they have hepatitis C infection. Now we have to focus the rest of the people that are not still treated and they continue to transmit the infection. So we want to think about patients that are in prisons, patients that are in night shelters, drug users. So for that, first of all, we doctors have to go and meet them in the place they live. We cannot wait for them to come to the hospital. We have to move and go there and treat. And for that is also very important simplified treatment. They are difficult to treat populations, so the simplified treatment is really important to achieve elimination. What can you say about simplified treatment? We have two pangenotypic treatments. They are really, really important to achieve this goal. So if we see soft-val, we have during 12 weeks, we have very high cure rates. The lower is in genotype 3, 95%, but we still now know that they are growing, so almost 100%. And also in child 8 treatment, in child 8 patients, sorry. But you can see, you can use also in child B and C patients, and if the cure rates are also very high. Also, glycoprotein Preventive you can use for 8, 12, or 16 weeks, and you also have a very high rates of cure, but we cannot use it in child B or child C. So what do you need to know? You have to know that they have hepatitis C infection. As soon as they have hepatitis C infection, we want to treat them. We see that in every stage of fibrosis, we can use soft-val during 12 weeks and glycoprotein Preventive during 8 weeks. And if we have some decompensation, and it's very easy to see, if you have ascites, if you have spontaneous bacterial peritonitis, if you have variceal bleeding, we know that we can have child B or child C patients. Maybe we use only soft-val for 12 weeks and with ribavirin. So what do you want to do in the future? We want to simplify everything. We want to simplify diagnosis. So we have to go to the community health center where to meet patients. We have to test, and in some minutes we have the result. And if they are positive, we treat on that day. 12 weeks after we go there, we meet them again and confirm cure. And if they are patients that have risk practices, for example, drug users, we might retest them and see if they are cured. So what is very important to achieve eliminations? Go and find the patients with hepatitis C and simplify not only therapy, but also treatment. So I invite you to follow all the webinars about with WHO, and very nice to meet you. Thank you. Bye-bye.
Dear colleague, I am Professor Benazzouz Mustapha from Rabat, a hepatogastroenterologist at Riyadh Nakhil International Clinic and a member of WHO Hepatology Interest Group. It's a pleasure for me today to discuss with you the opportunity for hepatitis C microelimination. Here the agenda. After an introduction on the concept of microelimination, I will discuss the microelimination in different geographic location, different setting, and in different population. First, the microelimination was proposed as a path to global elimination of hepatitis C by EASL International Liver Foundation. The concept of microelimination is based on breaking down national elimination goal into small goal for individual population segment, for which treatment and prevention intervention can be delivered more quickly and efficiently using target method. The microelimination have many advantages. It's a less complex process, less disappointing than national level initiative to suppress HCV, which need more people and a complex program. It's allow a faster and more efficient delivery for intervention. It is a reasonable approach to countries that are not yet prepared to fully implement national HCV elimination plan, and the situation can occur in many countries around the world. And finally, it can build momentum by producing small wins that inspire a larger effort. First opportunity is microelimination in different geographic locations, and I will give you two examples. The first one is from Egypt, in which the microelimination of HCV was done in rural community in 73 villages. A total target population was more than 220,000. The prevalence of HCV in this population was 16.5, which is so high. The HCV RNA positive was observed in 47 patients, and more than 99% of viremic patients were treated, and the SVR was 98.3%, which is a great success. The second example for microelimination in geographic location is in Cherokee Nation from North America. The Cherokee Nation launched a HCV elimination program in 2015 with a 6-fold increase in treatment in 2016. With this active program for HCV elimination, we can likely meet all elimination target from WHO by 2025. You can see in green line a great decrease in annual incidence, and we will meet all WHO target by 2025. The second opportunity is the microelimination in different settings, and I will share you 3 experiences. The first one is, why not test and treat all patients in present? Because this population is a high risk population for HCV. Here we have a nice experience from international study from 20 clinical cohort from 6 countries: Belgium, Canada, France, Italy, Portugal, and Spain. Around 526 patients were included. The effectiveness population was 442, and all of them were treated, and the SVR was 98.9%. And this good SVR was observed across all subgroup analysis: active IV drug users, antipsychotic drug use, genotype 3 with mental health disorder, genotype 3 with active drug use, genotype 3 with advanced fibrosis. The second experience in screening and treating hepatitis C in different settings is to do it in our emergency department from our hospital. And we can see this in this nice experience from Spain presented by Maria Bucci in EASL this year. More than 17,000 patients were tested. The prevalence of HCV antibody was 3.8%. A total of 128 patients were viremic, 69 were linked to care, and 38 were treated with 100% SVR. Most important is to note that 60% of all those patients would not have been eligible for screening due to lack of risk factor. And this strategy has been assessed as cost effective. Here we have the third example for microelimination in different settings. We can do it in our hospital, why not? But it can be difficult. But here we have a nice experience from Taiwan. In this hospital, we test and treat hospital personnel, outpatient surveillance, a callback system for anti-HCV patient, and oncologic patient who will take chemotherapy. In this study, more than 7,000 were tested, 764 were positive for HCV antibody, 138 were viremic, 135 were linkage to treatment, and 125 were cured. Now we will see the third situation where the microelimination can be implemented in different populations, and generally it will be done in high-risk patients. Here we have a nice study coming from England in South London, in which a mobile van was used. The team performed education, rapid testing, GenExpert RNA test, and finally treat the patient. 940 people were identified as homeless, and 933 participate effectively in the study. 56 were tracked on the street, which is very important because using a van, a mobile van. The prevalence of HCV in this population was high, 26. A total of 162 were viremic, 74 among them were initiated treatment, and the SVR was 75.5%. Another example for microelimination in high-risk patient, we know that hemodialysis patients are a high-risk population. We can say, let's test and treat all hemodialysis patients in my unit. It was done in Taiwan, in which 222 patients treated in a hemodialysis unit were tested. The seroprevalence was 14%. 15 patients were viremic, and all of them were treated with an SVR 100%. Most important is to note that in this study, an outreach team was set up to facilitate on-site blood sampling, fibrosis assessment by elastography during hemodialysis. The patient will not move to perform elastography. The outreach team come to unit and perform hemodialysis on site. So we will facilitate thing for all those patients. The outreach team also perform data monitoring and side effect management. Another example for microelimination in high-risk patient is coming from Punjab. In Punjab, the prevalence of hepatitis C among population is 3.6, but it is more higher than general population in Punjab in IV drug user, in which the prevalence is 8 to 10%. This program was done in an integrated care team at 25 sites, provided algorithm-based DAA treatment to IV drug users and supervised by a telemedicine clinic. The period for study was between June 2016 and July 2019. A total of 3,477 patients were included, and all of them were viremic. A total of 2,280 were completed treatment, and we have a follow-up after stopping treatment more than 12 weeks in 1,444 patients. The SVR was higher. It is 91%. The last example in high-risk population is coming from Australian experience in HIV-positive MSM patient. This population of patients were treated by nurse in 6 primary and tertiary care sites, and the per protocol SVR was 97% in primary care and 100% in tertiary care. More important is to note that we have not a great decrease in prevalence of HCV RNA positive prevalence from 57% in 2016 to 8% in 2018. So to conclude, we can say that the success of microelimination initiative rely to correct targeting of a population, of a patient population, or appropriate geographic context, identification, and patient setting. Microelimination, it is a key alternative strategy if elimination at national level is difficult to reach, which is possible in many countries around the world. Provided that community involvement represents a free pass for a successful program, microelimination will ultimately lead to a macroelimination program. And thank you very much for your attention.